Glaucomatous versus non-glaucomatous optic neuropathies, decoding with OCT, and it will be presented by Dr. Nishitha P. She has completed her glaucoma fellowship from Aravind Eye Hospital, Coimbatore, and now she is working in Shankara Eye Hospital, Coimbatore, as a glaucoma consultant. Over to you.
Thank you, Dr. Fahim. Good afternoon, everyone. So I'll be dealing with glaucomatous versus non-glaucomatous optic neuropathies, how to decode in an OCT. So Dr. Faisal has already given an elaborate talk on glaucoma as well as non-glaucomatous optic neuropathies. So I'll summarize. Okay, this is a normal OCT. So, So you have the RNFL thickness. You look at the RNFL thickness map, you find the normal dumbbell pattern where the RNFL thickness is normal and it is given in the red hot colors. You have the RNFL deviation map which gives the deviation from normal, and in this case you see there is no deviation. Then you have the TS-NIT graph for the NRR as well as for the RNFL. Normally it has a double hump pattern. You can see one hump for the superior RNFL and one hump for the inferior RNFL. This is the double hump pattern. Then you have the quadrant map and the sectoral map corresponding to each quadrant and the sectors. This is for a normal OCT. This is for a glaucomatous OCT. So you have the RNFL thickness map. You find there is a cooler colors for the inferior and the superior RNFLs. Okay, that means there is an RNFL thinning. The cooler colors like blue and green represent areas of RNFL thinning. So moving on to the deviation map, RNFL deviation map, you find there is a red color in the superior area as well as the inferior RNFL areas. That means there is a deviation from the normal. And as color coding was discussed earlier, that represents less than 1% that is seen in the population. So there is a definite RNFL thinning in these areas of redness. So in the TS-NIT graph also, you see there is loss of the double hump pattern. The double hump that was seen in the normal OCT is not there. Superiorly it is dipping, as well as you see inferiorly also there is a dip in the RNFL. And that is, this is for the NRR, this is for the RNFL. And you have the quadrant map again showing a red color in the superior quadrant as well as in the inferior quadrant. And on further sectoral map, you find the thinning is more for the supratemporal area and inferotemporal area, which is more specific for glaucoma. Okay. So the OCT GCC analysis for the same patient, you find there is thinning in the, this is for the GCC analysis also shows thinning for the GCC in the inferior as well as the superior quadrants. And for the GCC analysis, usually in glaucoma, the inferior quadrants are more involved than the superior quadrants. This is again an OCT of another glaucoma patient with primary open angle glaucoma. If you see the thickness map, you see a blue color in the inferior area corresponding RNFL defect or thinning in the deviation map. Again, there is the hump with the inferior aspect is lost correspondingly in the NRR as well as in the RNFL. The quadrant map also shows an inferior thinning and the sectoral analysis also shows an inferior thinning. And the GCC analysis of this patient shows there is a thinning in the inferior quadrant for the GCC as well. Okay. So this is the NTG patient we have discussed earlier. So in non-glaucomatous OCT, what are the features? So the cup-disc ratio will be normal. It will be given here. The NRR parameters will be given here in the OCT. So you have the cup-disc ratio will be normal. In non-glaucomatous cases, there will be more of temporal NRR thinning and temporal RNFL thinning will be there, or it will be a diffuse RNFL thinning. In glaucoma, we said the superior and the inferior quadrants are more affected, whereas in non-glaucomatous, you have the temporal RNFL and or the diffuse, there is a diffuse RNFL loss. The COP volume will be less, and there's other cases like neuro-ophthalmological, it is seen more in cases of optic atrophy that will be dealt with in the next talk. So this is a case of a 36-year-old female who had at presentation itself had anemia. On examination, she had temporal pallor. So the OCT revealed a temporal RNFL thinning, but you can see the GCC both eyes showed significant thinning in both the eyes. So this is a case of a nutritional optic neuropathy. The next case, this is another male, 68-year-old. He was a vegetarian by diet. Again, he came for a routine follow-up and was found to have bilateral temporal pallor. So again, an OCT revealed a temporal thinning, significant temporal thinning, and GCC map also showed significant thinning in both the eyes. So he was evaluated for blood investigations and his hemoglobin was found to be low. As he was a vegetarian, he was also, his vitamin B12 assay was also done, which was also found to be less than normal. So, and another importance on this case is that this OCT of the optic nerve head and RNFL can be used to assess the progression to, assess the treatment response to vitamin B12. Okay. So, this is just a word about disc edema, because we said all these optic atrophy result after a certain time after these optic neuropathies. Initially, they will have the picture of a disc edema. So this is a case of a 26-year-old female who presented with a headache and was found to have bilateral disc edema. She was later on diagnosed to have idiopathic intracranial hypertension. So in this picture, you can see all the parameters are supranormal. The OCT parameters are all white in color because of the increased thickness of the RNFL. Okay. So this case is like, this is a 36-year-old male who had presented with a large disc with a large cum. So in the OCT, you find the vertical CDR is about 0.9, but you find all the RNFLs and the RNFLs are in green. The superior and the inferior RNFLs are in green. So this is a case of a physiologically large disc with large cup where all the disc parameters are normal, but he had a temporal thinning. And further, his OCT GCC showed a CSR in the right eye, and he was an old case of old CSR in the left eye. That was the reason for his temporal thinning and GCC thinning. So this slide is here. You have to exclude all retinal and macular pathologies before you jump into glaucoma, looking at the GCC alone. Okay. Thank you.
Thank you. The excellent presentation, and now we can diagnose whether the disease is a glaucomatous or it is a non-glaucomatous. There are many tips in the OCT. If you go through it, if you specifically look at signs, we can very clearly differentiate. Now there is no glaucoma suspects. Now there is no disc suspect. Now we can just directly diagnose in most of the cases using the OCT if you interpret it properly.